Welcome to the Explainer. You know, some pharmacy consultations are pretty routine, but some are incredibly high stakes. Today, we're jumping into one of those, malaria prevention. We're going to give you the practical, down-to-earth insights you need to guide your patients with total confidence.
Okay, let's set the scene. You've been there, right? A patient rushes to the counter, they've got a trip to a tropical destination in just a week, and they have a prescription for an anti-malarial. This is so much more than just a transaction. It's a critical moment where your expertise can literally save a life.
So we're going to walk through this exactly how you'd handle it in the pharmacy. We'll kick off with why this is such a big deal, then cover patient risk and bite prevention, and then we'll get into the nitty-gritty, picking the right drug, the absolute must-know counseling points, and what to do with special populations. Let's get into it.
First things first, let's just quickly ground ourselves in why this conversation matters so much. When you understand the gravity of malaria, it makes it that much easier to get your patient to take prevention seriously.
So what are we actually fighting here? Well, malaria is this nasty parasitic disease, and it's all thanks to the female Anopheles mosquito. The parasite has this really clever life cycle. It starts in a human liver, jumps to our red blood cells where it multiplies like crazy, and then a new mosquito comes along, takes a bite, and the whole cycle starts over again. It's a relentless chain of infection.
And the global impact is just staggering. We're talking more than 600,000 deaths every single year. That number has actually ticked up recently, mainly because of disruptions in medical care. It's a stark reminder of just how important prevention is.
And let's be crystal clear, this is not just some bad case of traveler's tummy. The species Plasmodium falciparum is a real killer. A fatality rate of up to 20% in severe cases? That's terrifying. This is exactly why everything we do, from counseling to dispensing, is all about stopping the infection before it ever starts.
All right, so your patient is at the counter. It's time to put on your detective hat. The first, most crucial step is a really solid risk assessment.
And to do that, you've got to ask the right questions. It's not just what country. You need to know the specific region. Are they staying in a city resort or trekking through the jungle? When are they going? Is it the rainy season when mosquitoes are everywhere? And of course, you need their whole medical history, other illnesses, meds, allergies, and critically, are they pregnant or traveling with a child? Every answer helps you build that clinical picture.
Okay, before we even touch a single pill bottle, the conversation has to start with bite prevention. This is the absolute first line of defense, and it applies to every single person, no exceptions.
If your patient only remembers one thing from your counseling, make it this. The mosquito that carries malaria is a night owl. It does most of its work between dusk and dawn, so being super careful during those hours is probably the most effective thing they can do to stay safe.
Now let's talk repellents. You've got your two big players, DEET and Acardin. Both work great, but honestly, Acardin often gets the win for patient adherence. Why? Well, it lasts longer, doesn't feel as greasy, and doesn't have that strong smell. Plus, it's the go-to for kids over 6 months. And a huge clinical pearl for DEET users. Make sure you tell them to put their sunscreen on first, wait 10 to 15 minutes, then apply the DEET. It's a big deal for efficacy.
And don't stop there. Round out the counseling with these other physical barriers. Are they sleeping somewhere without good screens? They need an insecticide-treated bed net, period. And simple stuff, like wearing long, loose, light-colored clothes really does add another important layer of protection.
Okay, we've built our physical fortress against bites. Now it's time to talk about the drugs, the chemoprophylaxis. And the number one thing that drives this decision, it's all about where they're going and what the local drug resistance patterns look like.
This chart basically gives you the playbook. And let's be real, for the vast majority of places people travel to, we're talking most of sub-Saharan Africa, South America, Southeast Asia, you're going to be dealing with chloroquine-resistant malaria. So right away, that simplifies things. Your main choice is almost always going to be between two drugs, atovaquone, proguanil, or doxycycline.
Right. This is our time to shine. Choosing the right drug is half the battle, but making sure the patient takes it correctly, that's where we, as pharmacists, make all the difference.
Okay, first up, atovaquone proguanil, which you'll know as Malarone. The schedule is pretty user-friendly. Start a day or two before the trip, take it daily, and stop just a week after you get back. But here's the absolute non-negotiable counseling point. You have to tell them to take it with fatty food or milk. If they take it on an empty stomach, they barely absorb it and the drug could fail. Oh, and always screen for severe kidney problems.
Next, doxycycline. The first thing to flag is that they have to keep taking it for a full 4 weeks after they get home. That's a long time, so they need to be prepared. And there are two massive counseling points. One, it can cause serious sun sensitivity.
They need to be slathering on the sunscreen. 2, the risk of esophageal ulceration is real. They must take it with a big glass of water and stay sitting up for at least half an hour. And of course, it's a hard no for pregnant patients and kids under 8.
Then there's mefloquine. It's a weekly pill, which some people like, but look at that start time, at least 2 weeks before the trip. Why? Well, you're essentially doing a test run. You need that time to see if the patient can tolerate the potential neuropsychiatric side effects, which can be pretty intense. Weird dreams, anxiety, mood swings. It's absolutely off limits for anyone with a history of seizures or psychiatric conditions.
And speaking of side effects, this isn't just a minor warning. This is a direct quote from Health Canada, and you need to discuss it. We have to be blunt with patients that some of these effects, like dizziness or vertigo, aren't just a temporary nuisance. They can last for years or even become permanent. This is a huge part of making an informed decision together.
Okay, last but definitely not least, let's quickly cover a couple of groups that need extra attention: kids and patients who are pregnant or breastfeeding.
This table is a fantastic cheat sheet. So what's the big takeaway? Look at that pregnancy column. If you have a pregnant patient traveling to a chloroquine-resistant area, mefloquine is your drug of choice. You'll see atovaquone proguanil is generally a no, and doxycycline is completely out. This is a question you will get, and you need to know the answer cold. And when you're counseling parents, it's all about the practical stuff. Let's be honest, these meds taste awful, so give them some tricks. Tell them to crush the tablet and mix it with jam or chocolate icing. And suggest they ask the doctor to prescribe a few extra doses because you know some are going to get spit out. And hey, don't forget that compounding is always an option to make things easier.
All right, as you're wrapping everything up, these are your final mic drop messages. Number 1, and this is the most important. Any fever within a year of returning is a medical emergency until a doctor proves it's not malaria. Second, always buy the full supply before they leave. Third, remind them no drug is perfect, so bite prevention still matters. And finally, give them a written note reminding them when to stop their meds. Trust me, once they're home, it's so easy to forget.
You see, every one of these consultations is a chance to stop a medical emergency before it starts. By knowing the stuff inside and out, you're not just handing over a prescription, you're making sure that traveler comes home safe and sound. So, thinking about everything we just went over, what's one little thing you might do differently in your very next travel consult?